to see that they have not come, which means I'll be picking predominantly on Max and Jeff today.
And I haven't got a physiology book anymore that's up to date.
Oh no, I actually, mine wasn't very good either. I just purchased Josh had bought this Cunningham's veterinary physiology book, and it was so good. So I've just bought myself one, but highly recommended. Just the tone and the depth, because I did medical science before I did vet, so I had a medical science physiology textbook, which was perfectly sufficient going through uni. But yeah, this is much more specific for animals and much more relevant.
Right, yeah, I had one, a human one, Guyton, when I was taking residency. Yeah,
it's
that's very good, I thought.
It's very good, but a lot of it's not, particularly respiratory physiology, because there's such big differences between bipedal animals and quadrupedal animals.
Yeah.
Is that the right word?
Yes.
Yes, because bipedal animals have so much gravity that the top part of their lungs get so much ventilation, the bottom part of their lungs get so much perfusion. So there's always a bigger mismatch in bipedal animals as opposed to our animals who are forward and have more appropriately shaped lungs to deal with the effects of gravity. It's very interesting. Okay.
Yes, so just to get one thing straight, the lungs are those bag things between the diaphragm and the head, aren't they?
Perfect, that's the one, yeah. Big sacs, yeah. Good start. So I've done a really dodgy job here and literally taken photos of pictures from the textbook, and I'm just going to use them as conversation starters. But I do want to make it as, like, I'm so visual and so tactile and conceptual in the way that I learn. I don't learn very well from words. So I really want to be sort of focusing on the big concepts here. So if you've got any questions or points or ways that you think of things that really help, I think they're bound to help other people. So please jump in. The other thing with this, like, screen sharing, is I can't see you guys very well. So if you've all gone to sleep, I may not know. So please, if I'm being boring, tell me before you go to sleep. Okay. Okay, so just a quick review of the anatomy of the areas of gas exchange. So does anyone want to sort of walk us through the lower airway and the anatomy of the lower airway? That's you, Max.
Yeah. Oh, well, so main branch of trachea, and then branch of the bronchiole and bronchiole, and then all the way going to this alveoli.
Perfect. Exactly.
Yeah. Okay.
Yep. And so the alveoli are like little bunches of grapes on the end of the bronchioles, or the alveolar ducts. And the whole purpose of this structure is that it provides so much surface area. So if you sort of look at the inside of one of these clusters of grapes, there's heaps and heaps of surface area that can take part in gas exchange. We know from sort of small intestinal physiology as well as lung physiology, more surface area, the more diffusion will be able to occur. So we'll get better transfer of nutrients, oxygen, whatever it is, the more surface area there is. So I found interesting, the trachea divides 20 to 40 times before it gets to the alveolar level. So huge number of divisions. And in different species, there's actually communications between these alveolar sacs, but in dogs and cats there isn't. So each of these sacs is a single unit. All right, does anybody know what VO2 max is?
Is it like a venous oxygen saturation?
It is actually the maximum amount of oxygen that the body can use. So when it's at full-on exertion, it's the absolute maximum amount of oxygen that it will require. And obviously a very fit horse is going to use a lot more oxygen than a donkey. And same with humans, fitness dictates the amount of oxygen that your body requires to perform what you want it to perform. Okay, now this is just a quick review of how kind of the lungs breathe, because I think it's almost a nice visual of lung volume. So the lungs are these huge sacs, right? And normal breaths, do we know what normal breaths, what the volume or what the kind of term is that we use to describe normal breaths?
Tidal volume?
Yeah, excellent. So tidal volume is the inflation and deflation of the lungs within a sort of very relaxed normal range. The total lung volume is much higher than the tidal volume. So if the lung was to completely empty, that would be the total lung volume. But if the lung was to completely empty, it would never inflate again. So there always has to be some air left in the lung. That's called the residual volume. And this part of the lung, so residual volume plus it's called the vital capacity, is the potential, that sort of buffer you have in your respiratory system to compensate for increased demand of oxygen. So you've got probably roughly 4 times the tidal volume in volume that you can increase your depth of respiration to increase your gas exchange. Does that make sense? So just want to get that picture of the lungs kind of inflating and deflating, because then going into the next part where we talk about dead space, 3 different types of dead space. We've got equipment dead space. So for example, when we've got the ET tube in, anatomic dead space. So the whole kind of air movement apparatus. So any of the parts of the airway that aren't participating in gas exchange are anatomic dead space. And then we've got potentially alveolar dead space, and that's the areas of the lung that aren't participating in gas exchange because they're not getting blood flow. So it's just dead space, that the gas that's inhaled isn't going anywhere, it's just going to come back out again. So can anybody give us an example of equipment dead space? I mean, we sort of talked about the ET tube. Sorry, that's a bad question. I did something really blonde the other day. And hey?
I was going to say it's the ET tube.
Yeah.
Plus from the tip up to the bifurcation of the what do you call it? The 2 tubes in the anaesthetic machine, the Y piece.
Oh, yeah, the circuit. Should we just call it the circuit?
But that tube equipment dead space is going to absorb some of the natural anatomic dead space.
Yeah, you're right, exactly, because they overlap, don't they? Yeah, absolutely. So we had a little dog who was morbidly obese under anaesthetic the other day, and it was a pug, and obviously like they're so short, and the ET tube was hanging out of its mouth sort of that far. And then on the end of that, we had our CO2 monitor, a capnograph. And then on the end of that, we had an elbow going around to the anaesthetic circuit. So the amount of dead space we had outside the dog was really like way too much for this dog. And its CO2 was going up and up and up. And I said to the nurses, why don't we just move this part out so we got less dead space and see whether that impacts the CO2. And I was talking about the capnograph. So we wouldn't be able to measure the CO2 anymore. So let's just do a little visual on a super fat pug trying to breathe when we've suppressed the respiratory drive under anaesthetic. They've got to suck in enough air, so this entire volume of air. They've got to kind of do at least double that to push the air that's in the alveolar out, get new air down into the alveoli, and then breathe it back out again. So to be getting fresh air in the alveoli each time they take a breath in, they've got to be breathing in a much bigger volume than the airway holds. Does everybody understand that like concept of dead space?
Yep.
Yeah. Yeah.
Excellent. Anatomic dead space is less, I mean, we're designed to compensate for that. So it's less of an issue. It's really only when you've got stuff hanging out the front of the dog or cat that we end up in trouble. And particularly when there's suppression of the respiratory drive. Alveolar dead space is interesting, and we're going to cover VQ mismatch down the track. So this is exactly what this is. So when we don't have both the alveoli and the circulation working, then the gas isn't going to get into circulation. So we need to have both of those. Okay, so I want to, now that we've got this visual of the fat pug trying to take a breath, let's talk about the components of the respiratory, and I don't want to just say respiratory system and confine your thinking, but which parts of the body go into taking a breath in? Start on the outside.
The rib muscles.
Excellent, great. Are there any other muscles?
Diaphragm and maybe abdominal muscles.
Great, excellent. Good. Okay, now go in one step.
Did you mean?
Are you talking muscular?
So just inside the muscles.
The negative pressure in the pleural space.
Right. Excellent. Yeah, so the pleural space, the vacuum in there. And we'll talk about that in a little bit more detail as well. Okay.
Minus 3 millimeters of mercury, isn't it?
It depends a little bit on the phase of respiration. So the degree of vacuum when inspiration is triggered and the ribs go out, the degree of vacuum will increase, so the pressure will actually go down. And I've actually got a picture which demonstrates it quite nicely, and we'll talk about the different phases of respiration and the pressures in the pleural space there. Excellent. So then next step in is the lungs themselves. What elements of the lungs themselves will facilitate air movement?
The non-cartilaginous bronchi can expand under negative pressure.
Excellent. And do you know what the name is, what the term is for the degree of expansion that the lung can tolerate? So when we've got airway disease, for example, or pulmonary interstitial disease, and you just can like visualize trying to squeeze the bag and it's much harder to get the breath in, and we say there's decreased compliance. Excellent. Good. Excellent. So there's actually two. So compliance is the sort of interstitial component of the lung and how flexible it is, and how, if you think of it like a big balloon, the lung can be, there's actually a slide coming up about this, so I don't want to go into too much detail, but if you're trying to blow up a balloon with a really thick wall, you've got to try way harder than if you're trying to blow up a really thin walled balloon. So we want our lungs to be thin walled balloons and be able to inflate with minimal resistance. The other, so going sort of in from the interstitium into the alveoli, what force, this is a really hard question, but there's a force that wants the alveoli to collapse every time you sort of empty the air out of them. What keeps them open? Why don't they just collapse in on themselves?
Surface tension?
Good. Sorry. Surface tension is what makes them want to collapse. So that's one of the forces that is overcome by what mechanism?
The surfactant in the alveoli.
Great, King. Awesome. Did you read the textbook?
I tried, yeah.
Yeah, well done. Excellent. Okay, so if you, again, I'm so conceptual and visual. If you've got two pieces of like floppy plastic and they're a bit wet and you hold them kind of near each other like this, they suck together and stick together, don't they? So water or moisture will create surface tension, and it wants to close spaces. So if you've got water in your lungs, anyone can think of any diseases that we get water in our lungs?
Yeah, well, fresh or salt water near drowning
Beautiful, good example.
would
Yeah,
be one.
exactly. So what's going to happen to our alveoli when the surfactant has been washed out by water?
Collapsed.
Perfect. Yeah, exactly. And the other situation we see, or another situation we see that in quite commonly, fluid on the lungs, endogenous fluid.
Congestive heart failure.
Great, excellent. Yeah. So initially we'll get fluid in the interstitium, and then we'll get the fluid in the alveoli, and that will impact the alveoli ability to open, as well as obviously limiting gas exchange by causing a gap between the vessel and the alveoli itself. Excellent. So we've done lung, and now what about the actual airway itself? What will
Well-
impact air movement about the airway?
Well, bronchitis will, because it can stiffen the airway, and also exudate that goes into the lumen.
Yeah, absolutely. And what effect will that have on air movement?
Makes it more difficult to exhale.
And it will increase, is that R word?
The end expiratory push.
Resistance.
Resistant. It increases resistance to airflow. So if you've got anything causing narrowing of the bronchi, as in bronchitis, the swelling of the bronchial walls themselves, if you've got plugging of the bronchi with mucus, if you've got a hypoplastic trachea, it all has the same effect on air movement. So if you think about our little pug with his tiny little trachea and his massive inch of fat sitting on the top of his thorax, the amount of vacuum he has to create with each breath in to create enough negative pressure to pull air through a narrower space. Are we visualizing it? It's like breathing through a straw rather than breathing through your mouth. So you've got to create way more vacuum in your chest to suck more air in if there's resistance in your airways. And that's true of all our brachycephalic breeds with the upper airway. Depending on the breed, obviously, but on average, from the larynx up, creates 60% of the resistance to airflow in normal patients. The design, I mean, that's by design, because the air is supposed to be moved through in a turbulent way to humidify it and to move particles out of it. But you can see that if you then add another element of either increased resistance or lower airway pathology, you can end up with way more resistance to airflow.
Inversely, resistance is inversely proportional to the fourth power of the radius.
Yeah.
So a smaller radius has a really big impact on the resistance.
It's really profound, absolutely. So if you halve the diameter of a trachea, which is exactly what we see in bulldogs, you decrease the airflow by 4 times.
16.
16 times.
Yeah. Harvard is what, 2 to the 4th. 2 squared is 4, and 4 fourths is 16.
Yeah. So that has such a profound effect on the ability to move air and the vacuum that you'd need to create to suck air through that narrowed opening. Okay, is anyone asleep yet?
No, it's
You're
wide
all
awake.
right. Okay. Okay, so this is an image of the pressure in the alveoli versus the pressure in the pleural space in different phases of respiration. So this is at functional residual capacity. So this is at full expiration with just a little bit of our leftover air sitting in the alveoli. full expiration, no air moving. The pressure is equilibrated in the alveoli, is equilibrated with the external atmosphere. So there's 0 pressure in the alveoli, but we've still got -5 in the pleural space. And if you think about like that's actually one of the factors which stops the lungs collapsing, is that the rib cage is completely solid and there's this constant vacuum holding the lungs open. So then when you go to take a breath in, your intercostal muscles and diaphragm move out. They create more of a vacuum. So we've got more negativity in the pleural space. They suck the lungs out and it creates a pressure gradient between the outside world and the alveoli, which sucks air down the trachea and into the alveoli. Make sense? Then at the end of inspiration, lungs full of air. We've still got our chest fully expanded. We've got functional residual capacity plus the tidal volume in the lungs, but we're at equilibrium between the alveoli and the outside world. We've actually now got a vacuum of -8 to be able to hold that air in there at equilibrium. Then on exhalation, that vacuum drops a little bit. The air pressure in the alveoli goes up to 2, it becomes positive, which means that the air will passively move out into the atmosphere up the airway. Are you visualizing?
Yeah.
I held my breath while I learned this, like I was doing breathing exercises and learning the pressures. It really helps. So the actual air movement is passive. It's all about making sure that we've got functional rib cage, functional muscle function, functional pleural space, and then no restriction to airflow through the upper airway. So this is just a picture of the alveoli and the surfactant monolayer, which just prevents that surface tension snapping closed of the alveolus. This is such a flimsy structure. The fact that it doesn't just snap closed all the time is so remarkable. The surfactant is produced by one of these type 2 alveolar epithelial cells. And the rest of the alveolus, you can see that the cells here, the wall here is so thin. It's a single cell, and even then it's a really skinny cell. Okay, so we're going to talk about the different kind of impacts on the ability of the lung to expand. So 3 different situations. One is a normal alveolus, where you can see the alveoli is wide open and air movement is wide open. Scenario B is where we've got interstitial lung disease. So the wall of the alveolus is thickened, which means that the alveoli can't expand with air flowing into them. So you need more force to create the same degree of expansion as that thick-walled balloon. And then scenario C is where we've got a narrowing or increased resistance to airflow through the airways. And again, it's going to require more force to create the same degree of alveolar expansion. If we had an obstructive respiratory disease, what would our patient look like? How would you expect the breathing to look? Think about how bulldogs breathe.
Where's the obstruction, did you say?
Oh, upper respiratory, like airway obstruction.
Okay. So it would have expiratory dyspnea.
Yeah.
Expiratory excessive force.
Yeah. So
usually noisy.
Yeah. Yep. It's particularly if it's upper. It can be actually quite. It can be stridorous if it's lower, or silent actually. The other feature of an obstructive pattern, or obstructive respiratory pattern, is very long, slow breaths with increased effort. What do you see the abdomen doing when you see that respiratory pattern?
It's recruited more than normal.
Yeah, absolutely. So you get abdominal movement when there's increased respiratory effort. And the big difference between this high resistance respiratory pattern and this restrictive respiratory pattern, what are your breaths going to look like here?
Short and fast.
Good, excellent. So usually low respiratory rate with increased effort, usually fast respiratory rate with increased effort. Obviously, once you get hypoxic, they're all increased respiratory rate, but an obstructive pattern, much less likely to become hypoxic and much more likely to be taking really big sucks of air rather than little short, sharp ones. Okay, this is just a demo of the actual sort of blood flow around the bronchus and how the actual bronchus, or the bronchi plus artery and vein, run through the lung tissue. And essentially, sort of structurally, they're surrounded by alveoli. So there's alveolus right up against it, and then capillaries right up against it, and then they drain in and run through the lungs. I really like this diagram. So this is looking at different phases of respiration. So our lung volume, so residual volume, empty lung down here, functional residual capacity, and total lung capacity, so a full breath in. So obviously when you increase the pressure inside the chest, so when you increase the lung volume, it's going to squash some of the tissue. So you increase the size of an alveolus, it's going to squash the interstitium and the vessels in that interstitium. So at low airway volumes, the vessels running through that interstitium are going to be wide open and comfortable. At high lung volumes, you're going to squash the vessels and cause vascular resistance. Can someone describe sinus arrhythmia to me?
I can never remember which phase is which. But certainly the heart speeds up and slows down with phases of respiration. And I think it slows with inhalation, but I can't remember. I usually just listen to it on the individual at the time.
Yeah. You're right. It usually does slow right down with inspiration. Now, I'm not saying that sinus arrhythmia is caused by increased vascular resistance with an in-breath, but obviously the changes in thoracic pressure impact blood flow through the chest. So if you've got a constant vacuum in the chest, it's going to impact the ability of blood to flow around the alveoli, and therefore for the gas in the alveoli to be able to get into the bloodstream. And it's also going to impact the heart rate, because if you've got increased pressure in the chest, the right side of the heart is constantly going to be pushing under higher pressure to get the blood through that tissue. So it's going to be under more pressure. Does that make sense? Sort of. Have I lost you, Max? No.
Yeah.
Could you just repeat that, Anna?
So if you've got increased pressure on those blood vessels, so the two mechanisms of that are the alveolus is full and it's putting pressure on the interstitium and the vessel, or potentially you've got an interstitial disease which is squashing those vessels. You're going to get increased resistance to blood flowing around the alveoli. And if there's less blood flowing around the alveoli, the gas in the alveoli is not going to get into the bloodstream. You're going to create a VQ mismatch. So changes in pressure inside the lungs or in the interstitium, which will impact the vessels, will impact ventilation perfusion match. Does that make sense?
Yes, it does.
I think we've got a little bit more on VQ mismatch, so we'll talk about that a little bit more. I love this diagram. It's much better than the other ones we've looked at so far to describe the actual kind of blood gas diffusion barrier, the air-blood barrier. So on this side here, we've got an alveolus full of air. We've got the alveolar epithelium, really thin layer of cells. Then we've got the interstitium. Then we've got the capillary endothelium, again, really thin. These are the thinnest capillaries anywhere in the body, and they're really leaky. So they're designed to be as permeable as possible.
Gases.
So this really lets us visualize the limitations to gas movement if we've got alveolar disease, interstitial disease, or no blood flow. So can someone give me an example of a disease where the alveoli would be dysfunctional?
Well, paraquat poisoning causes destruction of the type 2 cells and hence loss of surfactant. So the
wow.
alveoli will be collapsed.
Great, excellent. So what will happen to our ability to get oxygen into the blood?
The alveolus will be collapsed, so there won't be any air in it.
Absolutely. So this blood, which is venous and deoxygenated, is going to stay deoxygenated as it moves past this alveolus. And that's not a problem if it's only 1, 2, 3, 4 alveoli. But if you've got half of the lung affected by that, obviously then you're only getting half of your blood oxygenated. All right, so what about an interstitial disease which might impact the ability for gas to diffuse across this barrier? What's an example?
Or neoplasia or congestive heart failure.
Yeah, good. What does congestive heart failure do to the interstitium?
Fills it with fluid.
Absolutely, exactly. So all of a sudden this space, which is so small, becomes really big. So gas is not going to diffuse as readily across this gradient. What about if we talk about an inflammatory interstitial disease, and then it's kind of got a couple of different components to it? What about if we talk about, say, toxoplasmal pneumonia, which causes an interstitial pneumonia? We're going to get infiltrates of inflammatory cells into the interstitium. And we're also going to get a change in the pulmonary capillary permeability. So on top of our inflammatory infiltrates, we're going to get leaking of fluid into the interstitium as well. There's just a couple of ways that the interstitium might become affected. All right, has everyone got this picture in their head? Because we might sort of refer back to that as we go through. All right. Okay, so now I want to talk about actual ventilation. So what causes hypoventilation? Does it actually, can someone define hypoventilation to me?
I guess it's the air movement. Well, it's, yeah, lack of air movement sufficient to either reduce CO2 sufficiently or increase oxygen sufficiency. I don't know which measure of chemicals.
Yeah. So
probably, I guess carbon dioxide is more the problem, isn't it?
It's more the measure with hypoventilation, yeah. So the body's really good at getting oxygen. It's not as good at, well, I guess we've got more of a buffer in our oxygen, how much oxygen we need and how much we actually get. It's if you're not ventilating, you're not able to get rid of the carbon dioxide. And if we go back to sort of visualizing that dead space image, if you can never breathe the CO2 out of the alveolus, it's just going to stay in there, which means that there's not going to be a gradient between the blood and the alveolus, and the blood is just going to hold on to its CO2 because there's nowhere for it to go. So if the alveolus has got too much CO2 in it, the blood will too.
Makes sense.
So when we talk about ventilation, we talk about the level of oxygen or gases, in fact, in the alveolus relative to in the blood. And that helps us pinpoint where the problem is, whether it's a problem with getting gas into the alveolus, whether it's a problem with the interstitium facilitating gas exchange, or whether it's a problem with blood flow. So we talk about that AA gradient, which is the alveoli to arterial gas gradient. So the difference between alveoli and blood gases. So we'll talk about AaO2 and the CO2 in the blood. And I want to talk about alveolar hypoventilation, which we just alluded to. So if you've got decreased air moving into the alveolus, what will the oxygen level in the blood be relative to the alveolus?
Geez.
Because it's going to be higher.
It's probably going to be about equilibrated, I would
Right.
say. So the actual ratio between the alveoli and the arterial, there's nothing blocking the movement of oxygen into the bloodstream. So they're going to be the same. The actual ratio is going to be normal. There might be less oxygen coming in. So the actual number might be low, but the ratio will be normal. What about CO2? The actual number of CO2 in circulation, the arterial CO2 in hypoventilation. Ron said it already.
Higher.
Yeah, absolutely. So if we think about tics as a classic, tic paralysis as a classic hypoventilation, we've got paralysis of those respiratory muscles. We're not able to move the intercostal muscles enough to create the suction effect. And we don't then move enough air through those alveoli and we get a retention of CO2. Okay, what about we're at the top of Mount Everest and there's a low atmospheric oxygen concentration, so decreased inspired oxygen. What's the gradient going to be? Is there any barrier to movement of what little oxygen there is into the bloodstream?
No, there'd be no, the lungs would be normal
Good.
initially, unless you get altitude sickness.
Yeah. So the ratio will be the same. The actual amount of oxygen will be low, but they'll be equilibrated. What about CO2 in this situation? What would you expect it to be in the bloodstream?
Probably low because you'd be hyperventilating.
Excellent. Yeah. So you're going to have to breathe more often to get the same amount of oxygen in. And that's going to mean that more CO2 is going to be moving out of your body. Okay. What about ventilation perfusion? So we've got decreased ventilation, but heaps of blood flowing through, which is essentially hypoventilation. Let's skip that one. What about a right to left shunt? What is our AA likely to be? So what if we've got...
I can miss the lungs, so...
Sorry about my dog.
So your blood oxygenation is going to be lower.
Excellent, good. So the alveoli is going to be full of oxygen, but the blood hasn't flown past it. So none of that oxygen has been able to get into the bloodstream. So the ratio is going to be high, alveolar to blood ratio. What about the CO2?
It'll be high.
Good, excellent, because it hasn't had an opportunity to blow that off either.
Yeah, it depends where the shunt is though. If it's just trying to think the name of it. The congenital one between the aorta and the pulmonary artery.
Oh, PDA?
Yeah, PDA. If it's PDA, you get differential cyanosis.
I know, it's so
The head gets, I think the head gets oxygenated, but the other way around. I think the feet get oxygenated, but the head doesn't.
I think
Is that right?
actually other way around. So the branch, so the aorta comes around like this, and then the PDA plugs in here, but the subclavian's already gone off to the head, so it's getting fully oxygenated blood out of the aorta, and then the shunt goes in here, and all the blood going caudally is deoxygenated.
Deoxygenated.
Yeah.
So it's the head that suffers. And,
No,
and the
bum
feet.
that suffers.
Sorry?
Bum that suffers. The head gets the oxygenated blood.
Okay.
And bum gets the deoxygenated blood. So vulval or propucial SpO2 relative to the lip will often be different. I'm going to skip diffusion impairment. That was just the answers there. Oops. Okay, so when we're really exercising as hard as we possibly can and we're heart pumping and we're breathing really fast, there's a really interesting phenomenon that happens. So when we're at rest, essentially the blood just creeps past the alveoli and it goes really slowly, and there's heaps of time for that gas exchange and for equilibrium between the gases to form. Whereas when we're exercising, the blood's flowing really fast, we actually impair our ability to get oxygen. And we compensate for that by recruiting more capillaries and increasing our inspired volume. So using that excess lung capacity. But it's important to note that when the blood's flowing faster past the alveoli, there's a limitation to gas exchange. And that's where we're going to run out of puff. That's where you fall over and stop exercising. Okay, so just want to describe VQ mismatch. So essentially, you need the alveoli to be getting enough gas, and you need the capillaries to be functioning properly to end up with oxygenated blood. So there's two different scenarios where you can have decreased ventilation causing hypoxemia. So in this scenario, we've got a blockage of the airway resulting in a low O2 in the alveoli and a high PCO2 in the alveoli. And you can see that the deoxygenated blood coming along here is exactly the same. So they've reached equilibrium, but there's no more oxygen to go in and we can't get rid of the CO2. So we're not going to change the CO2 or PaO2 levels if there's an airway obstruction. Then this is normal. So the PO2 coming in is 40. The PCO2 coming in is 40. So normally inspired air contains a PO2 of 100 by the time it gets down here. So we can see that the oxygen is going to move down its concentration gradient into the lower oxygen environment. And the CO2 is going to move down its concentration gradient out of the bloodstream into the alveolus. So we're going to get equilibrium. So that's a normal scenario. And then in the scenario where there's no blood flow going here, we're going to get a really nice equilibrium of the blood that's sitting here with a high PaO2 and a low CO2 because it's all been breathed off. But that blood's not flowing. It's not going anywhere. So it sounds like, you know, high O2 is not going to be a problem, but if that's not flowing, if it's not getting into circulation, it doesn't matter. Does that make sense?
Yes.
Okay. So looking at CO2 levels versus O2 levels systemically, we're going to have high CO2 levels and low O2 levels if there's an airway obstruction, right? Because we can't breathe off our CO2. So hypoventilation is going to lead to high CO2. Normally, we've got a pretty good balance between O2 and PCO2. But if we've got a perfusion blockage, we're going to end up with a very high O2 and low CO2. So it's just demonstrating the same thing, but more pictorially. The other thing I want to just talk about is this concept of right to left shunts with sort of regard to VQ mismatch. So V being ventilation, Q, I don't know why they made perfusion Q, but it is. We talk about right to left shunts and instantly we think about cardiac shunts being the sort of the obvious one, you know, PDA or VSD, which might reverse and go right to left. And what right to left means medically is deoxygenated blood going into systemic circulation or going onto the left side of the heart. So that can happen not just at a vascular level, but at a lung level. So if you've got, for example, a lobar pneumonia in this lobe and you don't have gas exchange because there's no air getting into the alveoli in that lobe, you're going to have deoxygenated blood flowing past that gas exchange area and into circulation. So technically, a VQ mismatch where there's decreased ventilation with normal perfusion is a right to left shunt. Does that make sense?
Yes, it does.
So in textbooks where you read right to left shunt, it's important to keep in mind that anything that where blood flow is maintained through an unoxygenated lung or not uninflated lung is going to mean that we've got right to left shunting. We've got deoxygenated blood going into systemic circulation.
Doesn't the reflex in the lung shut if it's not? Oh no, it's the reverse. Sorry, I think where the alveoli are not getting oxygenated, the lung reflex will shut down blood supply to that area.
Yeah, it's a really good point. So that sort of, I guess, is a nice segue, and we might avoid the oxyhemoglobin dissociation curve for the sake of boringness and time. Sorry. It's something it's talked about so widely. I don't really want to cover it too much. So let's talk about now the impact on blood vessels. So what thing, I'll just see if I've got a picture. I don't think I do. Okay, I'm going to stop screen sharing while we talk about this. So this is something that particularly people who are thinking about fellowships should get used to reading about the different chemicals that contribute to vasodilation and vasoconstriction, because it's uniform body-wide, and the more familiar you are with what these chemicals do, the easier it will be to just go to first principles when you're like learning about pulmonary hypertension and kidney physiology and stuff like that. So how does hypoxia cause decreased blood flow?
I suppose hypoxia causing inflammation and cell damage and trigger endorphin release and serotonin release and causing vascular constriction.
Excellent, really good. So initially, so that's exactly true. So endothelin is a really important one to mention for vasoconstriction, and inflammation will absolutely increase endothelin. Prostaglandins are another one that go along with inflammation that will cause vasoconstriction. And thromboxane. So when you get activation of platelets in particular, you'll get vasoconstriction as well. Hypoxia can trigger all of those with serotonin and histamine as well. So that hypoxia will cause vasoconstriction, which limits the flow of deoxygenated blood into circulation. So it just means less blood's going through an uninflated lung than the inflated lung. So we're getting less hypoxemia. What about the contributors to vasodilation? What chemicals can cause vasodilation?
Nitric oxide, that's endogenous on the vessel.
Very good. Excellent. And what, so that's endogenous nitric oxide. There's an inducible nitric oxide as well. Do you know what causes increase in nitric oxide production?
No.
It's shear stress. So when you've got very high flow rates or vasoconstriction, so increase in blood flow through that vessel, whether it's just due to increased cardiac output or increased vasoconstriction, you'll get resistance to flow through that vessel, and that will induce nitric oxide, which causes vasodilation. So it's that functional kind of reaction to shear stress. There's a couple of other ones that probably aren't too important as far as vasodilation goes, but let's talk, we've talked about the sort of humoral impacts on vasoconstriction, vasodilation. What about neurological inputs onto the blood vessels? And in fact, the bronchial walls we should talk about as well.
The sympathetic system, not adrenaline, and causing vasoconstriction because of the hypoxia and increased blood pressure.
Yeah, good. Yep. So sympathetic nervous system will increase vascular tone. What will it do to the bronchi? So we don't just have adrenaline being reduced locally. We've got it being produced at the adrenal medulla and going into circulation. So it's just going to impact everything. So what impact is it going to have on the bronchi, this bronchial smooth muscle?
Dilation.
Great. Excellent. Yeah. Do you know what the receptor is?
The guess beta.
Yeah. Beta.
The 2.
Great. Yes. Excellent. What drug acts on that receptor?
I was just thinking salbutamol.
Great. Excellent. Good. So sympathetic nervous system, you run away from a tiger, you need as much airflow as you can. So sympathetic nervous system activation is going to dilate your bronchi. What might cause, let me just make sure I get this right, airway constriction?
Probably acetylcholine, is it?
Great. Which is the neurotransmitter of choice for which nervous system in its postganglionic?
Parasympathetic.
Right. Excellent. So parasympathetic is going to lead to constriction of the airway via acetylcholine. There are some other things that can directly impact the smooth muscles and cause vasoconstriction, not vasoconstriction, bronchoconstriction, particularly relevant in cats. What are they?
Potassium. Bromide. Sorry, bromide.
Oh, bromide.
That's-
Come on. Yeah. I'm thinking more an endogenous thing.
Will be mediators of asthma, but I can't think what they are.
Yeah. What about, so we know that asthma is allergic in etiology. What causes allergic responses?
Histamine.
Yes, great. So histamine directly impacts
course.
the bronchiolar smooth muscle and causes bronchoconstriction. in sort of without any sympathetic, parasympathetic kind of overdrive, it will directly impact the muscle itself. All right. If we can flick back really quickly to, nope, I think we're good. Yeah, okay. Sorry, just checking we covered everything we wanted to cover. Does anyone have any sort of last questions or anything that they feedback or anything you want to cover?
So feedback was, it was a brilliant presentation because she made a complex situation simple. And that is true brilliance.
You're very flattering, Jeff.
It's a statement of fact.
I feel like I bumble along. If you do, the next one we're going to do is going to be cardiac physiology. It's going to be pretty full on as well. So any sort of structural change you want to make in the way that we're talking about these sort of pretty heavy topics, please just tell me, because I just want to make it as usable as possible. You don't have to be nice like Jeff.
No,
Can I ask, related to the last rounds we did, just about the crossover between cats with bronchoconstriction and without?
Mm-hmm.
Is that like a is there a continuum between cats with airway disease, or is it one or the other?
No, there definitely is, absolutely. So you know how in humans you get a virus and it causes bronchoconstriction. So all of those inflammatory mediators, histamine and things, will cause bronchoconstriction. So there's this huge continuum. If you've got chronic bronchitis in a species that's prone to bronchoconstriction, you're probably going to have a degree of bronchoconstriction secondary to that inflammation. Often chronic bronchitis in cats is terminal asthma. So it started as allergic asthma, and then they've had such severe obstruction of their airways, and kind of, we've talked about that chronic obstructive pulmonary disease syndrome, where if you kind of trying to exhale against a closed airway, your lower airways that are soft and don't have that rigid wall will blow out. And then you end up with a reduction in mucociliary clearance, and then you end up with chronic bronchitis. So definitely a continuum between them. And I find working out whether to use kind of cough suppression and anti-inflammatories, which will suppress immunity and will make chronic bronchitis worse, but asthma better. I find it really hard to walk that balance, and I feel like we get it wrong quite often, or we get it right for 6 months and then they don't come back in and then they've got pneumonia, and yeah.
And do some cats start with chronic bronchitis and then end up with bronchoconstriction secondarily?
Yes, yep. So I've got this patient who was desexed and within the 2 weeks after being desexed, developed a cough. Every single time it's completely resolved with antibiotics. It's now 3 years old, and then within 6 months it comes back again. So this cat's clearly had some either aspiration event or something under anaesthetic. It's got some damage to its lower airways, and it's really prone to bacterial bronchopneumonia. But every time it gets bronchopneumonia, we know it's antibiotic responsive, so it's not just asthma. We've cultured it so many times. There's a different thing every time. Every time it gets its bronchopneumonia, it gets really severe asthma, and we have to treat it with salbutamol as well. So absolutely there's a crossover between the two. And usually chronic bronchitis develops because of an injury to the lung. So a near drowning or aspiration event or something like that. It doesn't really come out of the blue. So chronic bronchitis might be caused by asthma, or it might be caused by another injury, but either way, in a cat or a human, you're going to get some bronchoconstriction as a result of that.
But less so in dogs.
Yeah, dogs just, their bronchial smooth muscles just aren't very reactive at all.
Yeah. And so that cat, it's not chronic bronchitis because it doesn't have a daily cough, but every 6 months it has a cough. So it doesn't fit the, like, is that the same in cats to make a diagnosis of chronic bronchitis has to have a daily cough?
So, Bronwyn, without taking too much credit, that cat only gets a cough every 6 months because of very tight management between episodes.
Right. Okay.
So, yeah,
Right.
he's on
Okay.
Fluxetide, and
All right.
interestingly,
Okay.
probiotics made a huge difference to this cat, and there's sort of new literature coming out
Ah.
saying that if you change the oropharyngeal commensal organisms, which probiotics have been shown to do, decreases the inspired bacterial load or changes them to a less pathogenic bacteria. But yeah, this cat's been very tightly managed.
Okay, cool. Okay.
We've got it down for 6 months, but it was like every pretty much.
Okay.
Yeah.
What
Cool,
about the
thank you.
cytokine storm that they describe in humans with SARS-CoV-2? That can be the terminal event, causing ARDS and so forth. And they found that an interleukin-6 blocker is so a degree of success in treating it.
I hadn't actually heard that, but it doesn't surprise me at all. So if we think back to that image with the alveoli, the interstitium, and then the blood vessel, and we think about, we use the toxoplasmal pneumonia as the example, we think about that interstitium, and as soon as you've got inflammation and cytokines increasing vascular permeability, you get a flood of fluid out of that capillary into the interstitium, and that becomes a barrier to gas exchange. So no matter how much you ventilate while you've got fluid in the interstitium at the degree that they're getting with COVID, there's just, you can't get the air in. And in those situations, that's where we're using the positive pressure ventilation. So we're keeping pressure inside the airways during, like at the end of expiration, to hold the alveoli open and almost apply pressure to the interstitium, because, pressure decreases swelling. So, we've got so many techniques to try and minimize that. We've got a real flood of fluid into the interstitium, but that is inflammatory cytokine mediated, that increased vascular permeability.
I think they mentioned IL-1 and 6 and tumor necrosis factor in this article I read.
Can I just say they're probably the only 3 cytokines you need to remember. They start everything. So particularly IL-1 and tumor necrosis factor alpha, they are the sort of initiators of sepsis, SIRS, MODS,
ARDS.
Hey?
ARDS.
ARDS.
Acute respiratory distress syndrome.
And ARDS essentially is just the lung version of MODS, basically.
Okay. Right.
Yeah. All right, we better wrap up. I better go to work.
Thank you. That was great.